Hello, good morning. Today we will discuss something about the terminal methods of contraception, like the irreversible methods of contraception or sterilization. In the male it is called vasectomy, in the female it is called tubectomy, as you know. 85% of the sterilizations take place in females and 15% take place in males. Each procedure averts is estimated 1.5 to 2.5 births per woman. There are certain guidelines for sterilization. The age of the husband should be between 25 to 50 years, and the age of the wife should be between 20 to 45 years. The couple should be properly motivated, and a motivated couple should have 2 children at least at the time of operation. The lower limit of the age of the husband or wife can be relaxed if they are having more than 3 children. None of the partners would have undergone sterilization earlier, and the acceptor declares that he or she has taken consent from the other spouse and knows that it is an irreversible operation. Now, coming to the vasectomy, the mechanism of action is as simple. As you know, the vasectomy involves the division of vas and ligation of the ends, so that the sperm during ejaculation won't enter into the genitourinary tract of the female. So it is easier than tubal ligation. Usually done under local anesthesia. The failure rate is as less as 0.1%. The vas starts from the lower end of the testis, passes around the bladder and enters the prostate, where the seminal fluid is added and it is passed through urethra. The vas is cut just above the epididymis level, and it is a piece of it is cut and the ends are ligated. The advantages of vasectomy are it is simple, inexpensive, and simplest effective. It can be done on OPD basis, minimal facilities. The cost effectiveness is much better. 5 vasectomies can be done in place of 1 tubectomy. Means the cost of 1 tubectomy is equivalent to the cost of 5 vasectomies. It does not affect the hormonal production. The disadvantages are it is a reversal of the method is difficult. Recanalization is very expensive, often unsuccessful. Sometimes, if the couple undergoes sterilization operation or vasectomy, if the child dies due to some or other reason, they want to undergo recanalization, which is expensive, and the success rate is about 20 to 30% only. So that should be very much explained to the party. Not effective until all sperm is cleared from the reproductive tract. As soon as the vasectomy is done, it is not effective. It will take certain time, about 12 weeks, or after about 30 ejaculations, the genitourinary tract will be cleared of sperm. So the person has to wait until such time. Complication of vasectomy. There are operative complications like any other operation, pain, hematoma, infection may be possible in 3% of cases. Sperm granules may be formed because accumulation of the sperm in the vas deferens may give rise to granule-like things which give rise to pain and swelling. Spontaneous decanalization may occur very rarely in 0 to 6% of the cases, but if it occurs, it is a serious complication. So, surgeon who is doing the vasectomy should educate the person prior to the operation, and he should follow up him regularly for about 3 years post-operatively in order to check whether there is any sperm in the semen. Autoimmune response is seen in about 54% of the cases. Antibodies are formed against the sperm, which reduces the fertility. There are some psychological complaints in some persons. They say there is reduced sexual vigor, impotence, fatigue, headache, etc. These are all psychological. There is no truth in it. The female sterilization is called tubectomy. It will be undertaken by 2 methods, either laparoscopic method or MINILAP. This involves mechanical blockage of the both fallopian tubes in the female to prevent sperm reaching the reaching and fertilizing the oocyte. Failure rate of tubectomy is about 0.5%. Now this is the genital system, internal genital system of the female, where the fallopian tubes are severed and ligated. Both ends are ligated on both sides. So these are the methods of ligation. Either they do ligation and cut, or they may apply some plastic band, or they may apply some clamp in order to block the fallopian tube. MINILAPAROTOMY. MINILAPAROTOMY is nothing but a modification of the abdominal tubectomy, earlier abdominal tubectomy, with small incision. In MINILAP, a small incision is given in the suprapubic region, 2.5 to 3 centimeters under local anesthesia, and the tubectomy operation is done. It is a revolutionary technique. It can be done at the peripheral level, the mass compounds, PAC, or even in the subcenter. Advantages of the MINILAP are it is safe, efficient, and easy to tackle the complications. More suitable for postpartum sterilization. Advantage of tubal ligation: it is a permanent method, highly effective, safe with quick recovery, lack of significant long-term side effects, and it is cost-effective. The disadvantages are there is a possibility that patient may regret, difficulty to reverse, future pregnancy could require assisted reproductive technology because tubal ligation has been undertaken. So if she wants again, the birth of a child, she has to undergo IVF, and there is no guarantee for preconception. It's more expensive than vasectomy. Laparoscopic tubal ligation. Abdomen is inflated with air or carbon dioxide or nitrous oxide under general anesthesia in a specialized center by a specialist. Follow rings are applied or clips are applied to occlude the fallopian tubes by means of an instrument called laparoscope. Indications. After 6 weeks of delivery, it is indicated, or just after medical termination of pregnancy, it is indicated. Hemoglobin level must be more than 8 grams and without any morbid conditions. Followed by lady health visitor is recommended between 7 to 10 days and between 12 to 18 months. Advantage: short hospital stay and short time procedure with a small scar. Complications: puncture of the large blood vessels may take place. Of course, it is rare. If it occurs, it is a serious one requiring major surgical procedure. Anesthetic complications may also occur in the laparoscopic tubal ligation. Abortion. Abortion is defined as a termination of pregnancy before the fetus becomes viable. The viability of the fetus comes after 28 weeks. So before 28 weeks, if the pregnancy is terminated, or if the product is less than 1,000, below 1,000 grams, it's called abortion. There are 2 categories of abortion. One is spontaneous abortion, which occurs in the proportion of 1:15. That means in every 15 cases of abortions, 1 spontaneous abortion will be there. Second type is induced abortion or deliberate termination of the pregnancy, either legally or illegally. Illegal methods are unsafe and hazardous, so legal methods are always recommended. Magnitude of the problem. Between 2010 and 14, worldwide, 56 million induced abortions occurred each year. 25% of all pregnancies ended in induced abortion. 50% of the global abortions occur in Asia. 7 million women approximately are hospitalized in developing world due to unsafe abortions. 30 abortions occur per 1 lakh women in developing countries against 220 per 1 lakh women in developing countries. ICMR documented proportion of unsafe abortions to safe abortions as 6.1 is to 13.5 per 1,000 pregnancies. Perhaps two-thirds of all abortions take place outside the authorized health services. Complications due to abortion, early complications like hemorrhage, shock, sepsis, uterine perforation, cervical injury, thromboembolism, psychiatric and anesthetic complications may occur. Late complications like infertility, ectopic gestation, risk of spontaneous abortion, and birth weight may be reduced. The optimal time for abortions is 7 to 8 weeks of gestation. 7 to 8 weeks of gestation is the ideal time. Risk of death in abortion is 7 times higher in the first trimester as compared to other periods. Legalization of abortion. Worldwide abortions are liberalized since more than 40 years. In India, abortions were governed by Indian Penal Code 1860 and Code of Criminal Procedure 1898. So in order to liberalize and legalize the abortions, Government of India brought MTP Act, that is Medical Termination of Pregnancy Act, in 1971, and it was passed in the Parliament in 1972, 1st April, except in Jammu and Kashmir. In Jammu and Kashmir, it was implemented from 1st November 76. 1992, the rules and regulations were revised. MTP Act is a healthcare measure to reduce the morbidity and mortality from illegal abortions. It also motivates the women to adopt some form of contraception to avoid unwanted pregnancy. MTP Act lays down certain conditions where it can be done, and the performer who has to do the MTP and the place where it should be undertaken. Conditions under which the pregnancy can be terminated are medical conditions, like any medical condition which may lead to serious consequences which affect the physical and mental health of the women. In such conditions, heart diseases, kidney diseases, liver diseases, those conditions, MTP can be done. Eugenic conditions. If the child born is handicapped, is expected to be handicapped or difficult to handle, and which give rise to mental ill health of the mother, those conditions required. Humanitarian notes. Pregnancy resulting out of rape will also be considered for MTP. Socioeconomic conditions. The socioeconomic conditions of the family are such that after the birth of the baby, it is difficult for them to nurture or look after the baby. Such conditions also MTP can be done. Failure of the contraceptives. If they have adopted a contraceptive method, suppose vasectomy or tubectomy, if it is failed and pregnancy is resulted, contraception is failed, then also you can advise for MTP. The unique feature of the law is that on request of the party, you can undertake abortion. In no other law, on request, some procedure is undertaken. And written consent must be taken from the guardian. If the lady is less than 18 years of age, or if she is more than 18 years also 18 years of age, but she is lunatic and under mental imbalance. Persons who can perform the abortion. One registered medical practitioner having experience in obstetric and gynecology can perform the abortion if the gestation is not more than 12 weeks. Two registered medical practitioners having experience in obstetric and gynecology to perform the abortion are eligible if the gestation is more than 12 weeks and less than 20 weeks. The place where the abortion can be done. MTP can be conducted in a hospital established and maintained by the government for the same purpose. A place approved for the purpose of MTP. Strict confidence is observed in abortion services. Abortion seekers' name is kept confidential. Now, medical termination of pregnancy rules 1975. The objective is to reduce the time consumption and ready availability of the services. Approval by the board is removed. Now, the chief medical officer of the district is empowered to certify doctor's eligibility to do MTP. The process of applying to board is removed to make the process easy and without taking much of the time. So, qualifications required to do abortion. For a registered medical practitioner to qualify, he has to assist a RMP, a registered medical practitioner, in 25 MTP cases in an approved hospital. Under new rules, the doctor may also qualify to do MTP with one of the following qualifications: 6 months housemanship in obstetric and gynecology, a PG qualification in obstetric and gynecology, 3 years practice in obstetric and gynecology for the doctors registered before 1971. 1 year practice in obstetric and gynecology for the doctors registered after 1971, because the MTP Act has come in 1971. That's why the doctors who are registered before 71, they should have 3 years of experience. The post 1971 registered doctors should have only 1 year practice in OBG. Place of MTP under new rules, which were released in 1975. Non-governmental institutes can also conduct MTP, provided they obtain license from Chief Medical Officer of the district. So this process eliminates the private clinics to obtain license from the board. 2013, an amendment is made to MTP Act 1971, in which decentralization of the power is approved. The power of approval of place from state to district level to enlarge network of safe MTP centers and service providers. To enlarge the network of safe MTP centers and service, they have decentralized from state to district. Strategy at community level. Spread of awareness on safe MTP services. The current path record అవుతుందా?
Current ఏమోనండి నాకు తెలియదు. లేదు సార్ కరెంట్ పోయింది. అడగదండి ఒకసారి అప్లై చేయండి.
ఒకసారి ఇంగ్లీష్
తెలుస్తాను.
రికార్డ్ అవుతుంది లేదా? వస్తుంది ఒకసారి తెలియదు. కరెక్ట్ పోయినా సరే కంటిన్యూ చేస్తున్నారు. In 2013, an amendment took place in MTP ACT with decentralization of the power from the state level to district level place. So, in order to enlarge the network of MTP centers and service providers, the strategy at the community level, spread of awareness on safe MTP services. Awareness should be spread at the community level. Different strategies should be adopted to improve the access to confidential counseling, promote abortion care through ANMs, Anganwadi workers, and ASHAs. Infrastructure at the place of MTP. Manual vacuum aspirators must be made available at community health centers, and at least 50% of the PSCs should have vacuum aspirators. The quality of the MTP services at the first referral units should be maintained. Encourage private and NGO sectors for quality MTP services. Abortions are less effective than the effective contraception, hence they are discouraged. So say no to abortion. Abortion should never be encouraged because we can have better alternative contraceptive methods. Now coming to the family welfare program. From 1930 onwards, India adopted family limitation program like birth control program. In 1952 only, for the first time in the world, India has launched National Family Planning Program, and there are several developments after 1952 onwards as regards the family welfare program, family planning program is concerned. So we have divided for our convenience to give you a comprehensive idea regarding the family welfare program. So from 30 to 52, there was only birth control program where some birth control clinics were there. Only some education material is being distributed, and innovative methods and other research was going on. By 1952, Government of India established National Family Planning Program. From 53 to 76, the clinic approach which was there under the birth control program is shifted to extensive education program. The LIPTES 2 was introduced in 1965 by Dr. Lippes, and the Department of Family Planning was separately established in the Ministry of Health in 1966. Thereafter, they started strengthening of the infrastructure. 1976, 1st April National Population Policy of India was formulated. The disastrous forcible sterilization in 1976 led to fall of the Congress Party in 1977. In 1977, the family planning program is renamed as Family Welfare Program by the then Janata government. The Congress government is lost because of disastrous forcible sterilization campaigning. Then rural health scheme was launched in 1977. 1978, India became signatory to the Alma-Ata Declaration in Russia. Alma-Ata Declaration is based on that attainable health, the maximum attainable health should be achieved by all by 2000 AD. So for which primary health care is the process which must be applied. So accordingly, World Health Organization has advised all the member countries to formulate their own health policies. As such, India has formulated National Health Policy in 1982. In 1985, Universal Immunization Program was launched in order to reduce the mortality among the children. Then in 1992, Child Safety and Safe Motherhood Program was launched. 1998 to 2020 is the latest era in which reproductive and child health program was integrated. Earlier in the 8th five-year program, all the health programs were concentrating upon the maternal and child health because they occupy 42% of Indian population, and health of the mother and the health of the child is of much concern. That's why several programs were concentrating upon the mother and child. So integration of all these programs took place in the form of reproductive and child health in the 9th five-year plan. In 2005, National Rural Health Mission was launched. In 2013, reproductive, maternal and neonatal child health plus adolescent health was launched. So each stage of life was given importance as regards the health. In 2014, Indian Neonatal Action Plan was launched, whose aim is to reduce the neonatal mortality to single digit and stillbirth rate to single digit. The Family Welfare Program of 1952 was associated with several misconceptions, hence renamed as Family Welfare Program in 1977 by the Janata government. The existing Family Welfare Program is a comprehensive one and related to improvement of the quality of life, promotion of the contraceptives on voluntary basis without any force or compulsion, with provision of information on various contraceptives. Now, the main characteristics of the Family Welfare Program are voluntary and informed choice, addressing unmet needs, improve range and quality of the services, removal of the demographic goals and targets. The earlier program of family planning, there was a little force, it was target oriented, target were fixed in the higher level, and they were throwing the responsibility on to the bottom level. Unmet needs were not addressed. So what the people need were not addressed. The quality of the services was not there. So all these components were included in the Family Welfare Program. So increases participation of men and women in the management, prevention and control of abuse by the program managers and providers. Earlier, the program managers and providers who are target oriented and goal oriented, they used to fix the targets and impose them on the medical officers and healthcare providers. So everybody was looking after the achieving the targets. So it prevents the control and abuse of the program managers. 1997, India launched Reproductive and Child Health Program. The philosophy behind the RCH program is that people have the ability to reproduce and also regulate their fertility. The components of RCH program are CNA, Community Need Assessment Approach. The difference between the earlier program and CNA approach are that the driving force in CNA program is community needs. The orientation is client oriented. The quality care is the concern of the program of the CNA approach. The goal is reproductive health. The approach is bottom up. From the bottom, the grassroots level health workers, they see how many number of cases are there, how many pregnancies are occurring, how many eligible couples are there, how many target couples are there. They fix the target and they pass on to the higher levels. Earlier, the top-down approach was there. The targets were fixed in the higher level and they were carried in the grassroots level. The goal was demographic impact earlier, and the concern was target achievement only. Orientation is provider oriented. The driving force is targets only. That is the difference. Integrated package of services. So all services are concentrated upon the MCH services, maternity and child health services. That's why integration of all services is needed in different sectors are involved and different programs are integrated to reduce the overlapping of the expenditure of the programs with the same aim and objectives. The MTP services and safe abortions at primary health center. Access to safe abortion services to women by improving the facilities at the primary health center or community health center, district hospitals. There should be accessibility, increasing the trained manpower infrastructure improvement. Unmet needs are also addressed. The services, the family welfare services which we are delivering should be available to the people. They should be accessible. They should be acceptable. They should be affordable according to their pocket. The method of contraception should have all these qualities. Then only people will accept the method of their choice to regulate the family size. There are 5 approved methods. Reversible methods are condoms, oral contraceptive pills, intrauterine contraceptive devices, and the permanent methods like vasectomy and tubectomy. These are there. We have to put forth before them and we have to counsel the people to help choosing the method which is suitable for them. And emphasis should be laid down on reversible contraceptive method because it is an unmet need. Increased male participation and no scalpel vasectomy is emphasized. Unmet need means people who want to undergo the contraception but they don't undergo because they don't want, because of various reasons, because of the pressure from the family, because of the pressure from the husband, etc. Adolescent health. Adolescents constitute 20%, 22% of the population. So intergenerational effect will be there by reducing low birth weight and child mortality rate. Teenage pregnancy, reproductive tract infection, sexually transmitted infection, nutritional disorders are the problems. All these problems must be addressed for the better health care of the adolescents. That is included in the recent family welfare program. The management of the STIs, RTIs, under RCH Program Screening treatment of the RTIS and STIS Syndromic approach. Services for prevention and treatment should be there. Improvement in the quality of the services up to the satisfaction of the client. You have to inform what are the available methods. You have to give a choice which is suitable for them. Interpersonal relations must be maintained, and competency among the service providers and clients must be maintained. Confidentiality must be maintained. Continuity of the care should be there. We should not tell and go away different methods, but we have to persistently follow and educate them, motivate them until the behavioral changes occur. The family planning method should become a part of their life. Gender sensitiveness. Women are involved in monitoring and planning because women empowerment is given a choice. Efforts to change the attitude towards women. So men should not have a differential attitude towards women. Gender issues as regards the developmental projects and programs are also included in the program. Communication strategy in RCH. The communication strategies can be changed from area to areas. There must be area-specific communication strategies to create demand for RCH services and to promote the informed decision-making on the health matters. Emphasis is laid on the interpersonal communication. To use local traditional media for increasing acceptance, thereby to bring about the behavioral changes. Gather approach is an approach for the contraceptive counseling. These texts will treat them politely and friendly, ask them what is their need and requirement, tell them what is available, what services are available as regards the contraceptives, help them to choose whichever method is suitable for them, explain the side effects and adverse effects and their failure rate, etc. to the party and revisit and follow them. And the last but not the least is greater involvement of the NGOs, non-governmental organizations and Panchayat Raj institutes. The Panchayat Raj identifies the needs of the people for RCH services. It supports financially and arranges transport and different services to the women in need. It also evaluates family welfare program and client satisfaction regarding reproductive and child health. NGO involvement is very much essential. They have the flexibility of their services, which is a major strength of the NGOs. They enjoy the better rapport and credibility among the people. Government of India expects NGOs to undertake innovative efforts through special projects and funded by Government of India. Small NGOs are involved in counseling, advocacy, awareness among the people about the RCH. Regional NGOs extend their assistance to small NGOs. The evaluation of the contraceptives. There are two methods of evaluation of the contraceptives. Evaluation is nothing but efficacy of the contraceptive method is assessed by measuring the unplanned pregnancy during a specific period and use of contraceptive methods. Two methods are there to evaluate them. Pearl index, which is the failure rate per 100 women years, is equal to total accidental pregnancies per 1200 total months of exposure. The life table analysis is also done to evaluate them, calculate the failure rate for each month of use. The cumulative failure rate can compare methods for any specific length of exposure. Failure rate is taken into consideration in life table analysis. Evaluation of family welfare program. 5 types of evaluations are recommended by World Health Organization Expert Committee in 1975. Evaluation is the process of making judgments on objectives by comparing them with specific value standards for deciding alternative course of action. 5 types of evaluations are evaluation of the need, evaluation of the plans, evaluation of the performance, evaluation of the performance, evaluation of the effects, evaluation of the impact. Evaluation of the need, depending upon the need. Suppose MMR is more in a particular area, we have to create the demand so that they come for services of the RCH and family welfare services. Evaluation of the plans, whether the plans are adequate or not, whether the feasibility of application of plans are there or not. Evaluation of performance regarding the services, what services are available, whether mobile services are available, emergency services are available, or contraceptive distribution is proper or not. The response, how the people are responding, how many people are accepting the family planning procedures, the cost and how much cost incurring. All these things are studied. Other activities like administrative activities, manpower, data system, etc. should be evaluated. Evaluation of the effects, their knowledge must be evaluated. Attitude and practices, how far they are motivated, the gap studies can be done, and motivation levels can be measured in order to change their behavior. Change their behavior can be noted. And evaluation of the impact, what is their family size earlier and now, what is the birth order, what is the abortion rate, and age of the mother, the first birth, age of the mother, and the last childbirth should also be evaluated. Thank you very much. Family welfare program in India in near future may be accepted as a way of life. Thank you.
अभी एक साल 2 साल कम हुए आज रिकॉर्ड होता लेता है डाउट हमको सबसे बात है आप इस डाउट है